This is Willie Kemp. So this is the third lecture on anemia. This is conditions causing increased destruction, part 1, and there'll be 3 parts to this. So there are the websites. As I said, once again, there are 2 websites me and Dr. Hughes have that have questions for the USMLE. We haven't worked on in a while, but I might start working on those again. There's my 2 Twitter signs, and I haven't posted in a while, but I might start doing that again. And once again, I'm a forensic pathologist, but I have a very strong interest in general and organ pathology, and a very strong interest in teaching medical students. The disclaimers for the lectures are here. Read these disclaimers. If you disagree with any of them, do not watch the lecture. There's the first 2. There's the third one. And then at the bottom, if you're interested in my teaching style or wonder why I do things the way I do or anything like that, watch that presentation. It's not necessary, but if you want to understand why I present things, then that kind of explains it. Here are the references again. Like I said, these are the references I use to make the lecture. Really some good books here, very useful. The Clinician's Guide to Laboratory Medicine really helps give you a differential diagnosis and way to look at how to look what lab tests to order to make different diagnoses. And Dr. Stern's book, great on key features in differential diagnosis to help you distinguish conditions. I wish both of them had been around when I was in medical school. They weren't. And once again, I have no financial interest in either one of them. I just think they're great books. So again, these are specific conditions leading to increased destruction of red blood cells. First things first, we'll do a question. So once again, pause, look at it. If you don't know the answer, that's great. Just look at it, try and come up with the answer, and then we'll talk about it at the end. And it's just a way to guide you as you're viewing the lecture, and help you retain material. Okay, so hereditary spherocytosis. So what I did with these conditions is I tried to make as few slides as possible, but I tried to organize them, and my general organization is this. I go basic features, and I'll talk about the etiology of the anemia. So this is increased red blood cell destruction. It's an intrinsic defect of the red blood cell cytoskeleton. And so you can go back to that and think about the differential diagnosis we did with lecture 2 and how to guide it. The mechanism basically is you have non-deformable red blood cells. So think about it. If the cytoskeleton is damaged, red blood cells have to deform a lot when they're squeezing through the capillaries and stuff like that. And so if you mess up their cytoskeleton and they can't deform, they won't squeeze through capillaries as well. And so they can get stuck, they get sequestered. That's why with hereditary spherocytosis, you can see splenomegaly, and they can get subsequently destroyed. Genetically, it's usually autosomal dominant, but it says there are some recessive ones. It's some defect in the cytoskeletal protein or something that the protein anchors to, or that. It says the common ones you see are spectrin, which is kind of like in the picture I saw kind of a submembrane mesh that forms. Band 3, which is a transmembrane protein, and ankyrin, which binds spectrin to band 3. Those are the 3 main ones. There are other mutations that are possible. Pathologically, with hereditary spherocytosis, you see smaller red blood cells with no central pallor. So remember, with a normal red blood cell, you'll see some degree, maybe a third of the cell in the center will be pale. But with these, they'll be all red. And then other features you can see, splenomegaly, as I just said, because the red blood cells kind of get stuck and can lead to enlarging the spleen. And then because you get breakdown, you get extravascular hemolysis. Remember, this is increased destruction of red blood cells. You get extravascular hemolysis. You're going to get an elevated level of unconjugated bilirubin, and that can lead to potential for gallstones, the pigment stones. So here's an image with hereditary spherocytosis, and I've shown with the black arrow kind of some of them, some better than others, but you'll see all the ones in there that have a essentially no or very little or no central pallor. Would be what you would see with hereditary spherocytosis. And remember, on some of these smears, you can see 2 populations of cells. The reason being is there's a good chance that if they have a normal population and a pathologic population, they're probably transfused. So some important points. There's a testing called the osmotic fragility test. If you put the red blood cells in a hypotonic solution, water is going to go into the cell. But because the spherocyte cytoskeleton is damaged, it doesn't deform the way it should. It can't swell. And when it tries to swell because the water's coming into it, it'll burst. Another thing is because you have breakdown of red blood cells, you have you have more demand for red blood cells to be produced. So if you get anything that targets those immature red blood cells, i.e. parvovirus B19, and destroys them, that can lead to a crisis because you need those young red blood cells and you're not able to produce them because of that. Okay, another form of increased destruction is sickle cell anemia. This one, the etiology is it's increased red blood cell destruction because of an intrinsic defect in the red blood cell, and that is abnormal hemoglobin. Very common in the United States, 8% of blacks are heterozygous for hemoglobin S, and it says 1 in 600 are homozygous. So I'll mention it later, but one of the reasons for this is because such a high number is because sickle cell is supposed to be protective against Plasmodium falciparum. And so this is a way that you can have a really bad condition, because sickle cell anemia is a bad condition that has a pretty high morbidity mortality rate, can survive in the population because there's an advantage to it. So the mechanism, it's a mutation in the beta globin chain that substitutes glutamate for a valine, and it's on the outside of it. So glutamate is normally hydrophilic, and it's on the outside where you want the hydrophilic residues. But if you put valine in its place, which is hydrophobic, that's abnormal. And now you have a hydrophobic residue in the middle of all these hydrophilic, and it just makes the cell sticky. Pathology, you see sickled red blood cells, and that damages the red blood cells, so they are destroyed, hemolyzed, and then also they can basically sludge and block up things and cause obstruction. We'll go through that. You can see erythroid hyperplasia, as I talked about, because you're breaking down the red blood cells. You want to produce more of them, so you have a higher level of erythropoietin stimulating it. You get bone marrow expansion. It actually says it can cause a crew cut appearance because of the bone around the bone marrow expansion. And then you can also make red blood cells in not usual locations for adults, i.e. liver and spleen, which can lead to hepatosplenomegaly. And then because you're getting breakdown of the red blood cells, that releases the hemoglobin, you get unconjugated bilirubin. That can lead to gallstones, and also you can have hemosiderin deposition as the red blood cells break down. For example, in the spleen, they can deposit the iron there. So here are some things associated with it. To the left, these are sickled cells. You can see at the arrow. To the right, what those are is hollow jolly bodies. So hollow jolly bodies are actually characteristic of, most commonly it seems like post-splenectomy. So a lot of people have splenectomies who don't have sickle cell. But in sickle cell anemia, as I'll talk about a little bit, they have autosplenectomy. So basically, in the beginning, they can have a larger spleen, but over time, they'll get a small spleen, and basically, because it infarcts in that and gets small, and so they can have basically, they basically splenectomize themselves, and then you see hollow jolly bodies. And the bottom right is just the liver sinusoids, where you see the sickled cells. And so we're going to talk about kind of the mechanism behind sickling. So just think of that like in the central lobular part of the liver, where you have the lesser oxygen levels and stuff like that can lead to the sickling. So this is just my slide to remember where I'm at. I think most of these lectures I was shooting for 10 minutes. They're probably going to be about 20. Sorry, but still breaking them up. So this is a Billings Zoo. Also, Bismarck Zoo has this. They both have two bald eagles. Really neat. They're both, all four of the eagles were eagles that were injured. They were able to bring them in and care for them, and they can't fly. There's nothing over the top of them, so they could fly away if they wanted to, but they can't fly because they were injured. So it's pretty neat to see these animals have a life that they wouldn't have had out in the wild. Okay, so the basic mechanism of sickling is kind of here. This is my drawing. I hope this is okay, but you see a red blood cell at the top left. With hypoxia, you get sickling. With reoxygenation, it goes back to normal. The problem is when you cycle like that, eventually the cell gets where it's irreversibly sickled. And it says calcium will enter it, potassium will leave, and it becomes irreversibly sickled. So some things will prevent sickling. For example, hemoglobin A. The main hemoglobin in the adult body is hemoglobin A, and that actually prevents sickling. So that's why individuals with sickle cell trait would have half hemoglobin A, half hemoglobin S, or almost, actually have much less chance for sickle cell crises than somebody with sickle cell anemia, because hemoglobin A helps prevent it. Hemoglobin F also prevents it. So early on, there's less like sickle. So until that passes in people who are have two sickle cell genes. Actually, at first, when they're still hemoglobin F, they are not going to sickle for about the first 6 months. And then also, if there's a reduced amount of hemoglobin, not as easy for it to interact. So if you combine thalassemia with it, sometimes you'll have less sickling. However, some things promote sickling. You can think anything that dries things out, make it more sludgy. So dehydration, anytime you make the red blood cells more prominent, the fluid less, that's going to promote it. Infection, inflammation can do it. Sluggish flow can do it. And then hemoglobin C is unlike hemoglobin A, hemoglobin F, and it actually causes more aggregation of hemoglobin S. And so it promotes sickling. So some of the effects of this, you can imagine with those sickled cells and stuff like that, with sludging in the vessels, it's going to block the vessels, which can lead to thrombosis and infarction. You can get ischemia of the bone marrow and very painful crises. I remember when I was in medical school, we had a lot of patients who had sickle cell anemia who came in repeatedly, had to have treatment for pain in that, and can also contribute to priapism. And then to the bottom right, that was just me. I thought, okay, so if you look at sluggish blood flow and hypoxia, that leads to sickling. Sickling can lead to vaso-occlusion, which is going to lead to more sluggish blood flow and hypoxia. So it's kind of a recurring cycle where it just feeds upon itself. So this sickling and this obstruction can lead to various types of vaso-occlusive crises. So one is the hand-foot syndrome. This is due to infarct of bones in the hands and feet. Acute chest syndrome is another one. This is usually associated with an infection. And remember, infection promotes sickling. And so with this, they'll get a pulmonary infiltrate kind of on top of the pulmonary infection. And the sickling can occur due to the sluggish blood flow, but it can also, you can see actually fat emboli from bony infarcts can also contribute to acute chest syndrome. Stroke can result if you have blockage of blood flow in the brain. And then they can have a proliferative retinopathy, which leads to a loss of visual acuity and blindness. So just some other important points for sickle cell. I already mentioned the first one, but one reason why sickle cell, which is a bad disease, is in such high concentrations in the black population is because it is protective against Plasmodium falciparum. So individuals with sickle cell are more likely to survive malaria, and therefore has allowed a bad disease to stay, even though it normally should, there'd be no reason through evolution for it to stay. And remember, as with hereditary spherocytosis, when you're depending upon red blood cells being produced, because your red blood cells don't have the normal 120-day life expectancy, anytime you have damage to the precursors, i.e. through a parvovirus B19 infection, you can cause a crisis because you're not producing the cells that you need. We talked about hemoglobin A. Hemoglobin A2 is also produced, hemoglobin F, and then the hemoglobin S. And this just gives you kind of some general numbers. So a sickle cell trait, it's not actually 50-50. You actually have a little bit less hemoglobin S than hemoglobin A. But in sickle cell anemia, it says they'll retain anywhere from 1 to 40% of their hemoglobin will be hemoglobin F. And obviously, the higher that is, I would assume the better the patient will do, since the hemoglobin F inhibits sickling. So this is just another way I created to kind of think about what can happen with sickle cell anemia. So you basically get microvascular occlusion because of the sickling and the sludging of the cells, and that can lead to hypoxia, which leads to infarction. That can cause autosplenectomy. You can also get other organ infarcts, the bone, as we talked about, and then bony infarcts can lead to fatty emboli. Fatty emboli can lead to acute chest syndrome. But basically, most organs can have that. Also, through the microvascular occlusion, you get entrapment of red blood cells. That can lead to splenomegaly and priapism. So early on, patients with sickle cell anemia will oftentimes have a large spleen, but then over time can develop a small spleen through the autosplenectomy. And then when they lose a spleen, they're at risk for encapsulated organisms. And then remember, salmonella osteomyelitis is usually commonly associated one with sickle cell. So not only do they have microvascular occlusion, but they also have a chronic hemolytic anemia. They have an abnormal hemoglobin that causes breakdown of the red blood cells. So that's going to cause hyperplasia of the erythroid precursors. When you're losing red blood cells, you're going to stimulate the bone marrow to make more. And then that bone marrow can, the proliferation of bone marrow can lead to changes in the bone, and that's what gets that crew cut type appearance on the radiograph. And then it can get to the point where it makes it other places than just the bone marrow, so you can get made in liver and spleen, which could contribute to hepatosplenomegaly. And when your red blood cells are breaking down, they're going to be broken down oftentimes in the spleen, which is removing them. So you get an extravascular hemolysis, which is going to lead to elevated unconjugated bilirubin, which leads to gallstones, pigment gallstones, and also because you have red blood cells breaking down in an extravascular location, you get hemosiderosis. So here's the question again. So pause, answer the question now, and then we'll go on to the answer. Okay, so pathology resident examining a blood smear during her hematopathology rotation and finds the following red blood cell morphology. Of the following, what mutation does the patient most likely have? So those are sickled cells, and so remember, it's a mutation that produces a valine for glutamate substitution. So where glutamate was now becomes valine, and it's on the beta globin chain. And then once again, just pause and use reflection. Go back and think, okay, what are 5 things I learned during this lecture? And with this technique, I'm hoping you always have learned 5 things from the lecture. But like I said, once again, it's a really powerful tool to help you learn the information. So here's the red panda again. I always look at this and I think of my kitty cats reaching out for something and everything like that and stuff. So just a cute little guy there. So I hope this lecture has been useful to help you understand anemia. And thank you.